All right. Well, welcome you guys to our headache school. Thanks for joining us. I think we'll get started. Um, Let me know if you can't hear me or something, but it looks like my microphone is working. So um, I'm Jared Bartell. I'm a neurologist at the University of Utah. I'm a headache specialist. Um, and I'll be talking today about dizziness and migraines. This part of the talk should be about 20 or so minutes. Feel free to ask any questions in the chat, which I might not see until the very end, but um, let we can ask the questions at the end too. And the last 30-40 minutes or so will be kind of a question and answer session too, so we can always go over anything and go back over previous slides too as we need to. So all right, well, let's get started here. So there we go. Okay. So just as an outline, so I'll be kind of talking about a representative case first, about a patient that I had seen a couple of years ago. We'll go over kind of what we call the differential diagnosis or possible causes of this type of a presentation. We'll be then talking about vestibular migraine mostly, and then this other kind of unusual phenomenon called persistent postural perceptual dizziness, or 3PD, which we'll go into, of course, in more detail. And then there'll be the question and answer session, which won't be recorded. And at that point, you can turn your microphones and your cameras on, or whatever you'd like, you feel comfortable with. Okay, so this was a patient that I saw a little ways back. She's a 45-year-old woman who's a social worker who has a strong family history of headaches and longstanding personal history of car sickness and motion sickness. Who's presenting with 10 months of persistent vertigo, which she described as turning, tilting, spinning, kind of feeling like she's drunk, with some ear fullness in both ears, which is worse around the time of her periods, as it turns out. And she has some light and sound sensitivity as well, some nausea, but not a lot, and it's worse while she's driving. And then more recently, about 6 months ago, when I had seen her, she started to have some headaches, which had picked up quite a lot. They were a lot more infrequent before, and now they're a lot more frequent, up to 10 to 15 days per month. They're severe throbbing. It's kind of like a crushing pain lasting several hours, located on the top of her head, with light and sound sensitivity, some nausea, and it's worse when she is physically active. And it's associated also with some vertigo symptoms. She's on a few different meds. None of them are really a cause. We think about medicines often as like a cause of vertigo or dizziness, but none of those were really thought to be contributing. She was actually on verapamil, which, as we'll talk about, is actually a treatment for vestibular migraine. And then she's also on a few different supplements, which we're not really talking about today, but those coenzyme Q10, vitamin B2, or riboflavin, and magnesium are actually also helpful for migraine in general. But not specifically vestibular migraine, but they can be good. She has a normal neurological exam. Her MRI scan was normal. And then she actually had ENT testing, like ear, nose, and throat, kind of just evaluation in her ears, which was normal. And then she saw physical therapy for vestibular testing of various kinds, and that was also normal. All right. Okay. So when we think about a differential diagnosis, or like what are the possible causes of dizziness, we kind of break it up into causes that could be coming from the brain itself, or the brainstem, versus causes that could be coming outside of the brainstem, like the nerve that travels up. I guess my mouse is over here. It travels up past the brainstem into the inner ear. So the inner ear and nerve are called the peripheral problems. The brain, of course, is the central problems. We'll be talking mostly about these two brain causes, the vestibular migraine and persistent postural perceptual dizziness, or 3PD. But there are other things to consider also, which we often need to look at with like an MRI scan or something like that, additional testing to kind of evaluate, the differences. So things like vestibular neuritis, which is inflammation of the vestibular nerve, which is the nerve that connects the brainstem to the inner ear. This benign paroxysmal positional vertigo, which is another mouthful, but that's a different type of a problem where you get little, like the circular part of your, actually up here, the semicircular canals can develop these little kind of stones, and they get stuck, and they can cause persistent perception of spinning or vertigo. which if you've had BPPV, you know exactly what I'm talking about. It's kind of an unusual thing, but it does happen quite often, or at least we see it often in neurology. Meniere's disease, which we're not really going into in detail today either, but this is a problem that affects the inner ear that can also cause hearing loss and ringing in your ears. There's a cause of dizziness that comes from your neck called cervicogenic dizziness. And then acoustic neuroma, which is kind of like a tumor on that nerve that connects the brainstem to the inner ear. And then we'll be talking about those two central causes. Stroke is also a possibility, or some sort of blood vessel problem. A Chiari malformation, which is kind of like where the brainstem and the balance center kind of sinks down below where it should, and that can cause problems. And then multiple sclerosis, people always worry about too, but you know, we look at that on an MRI scan, and we can usually often say yes or no, but sometimes it's kind of borderline cases and where we need to do additional testing. So our patient's diagnosis that we just talked about was diagnosed with migraine without aura. She didn't have any clear like aura symptoms, usually visual symptoms preceding the onset of the headache. Menstrual associated migraine, where your headaches tend to happen more often around the time of your period. But what we will be talking about is vestibular migraine, which she also had, and then, excuse me, this 3PD phenomenon too, which we'll talk about towards the end. So just a brief word about dizziness and vertigo. So I'll be kind of using these words, I mean, unfortunately, a little bit interchangeably, I think, but I'm going to try to be careful with it. To a certain extent, it is very important to distinguish between these because it's helpful diagnostically to make the distinction. A lot of times, once we know the diagnosis, the kind of whether somebody is having, you know, like one type of dizziness versus the other, it's often all treated the same as long as we've kind of ruled out the peripheral causes, that left-sided column. If we think it's like a vestibular migraine, you know, if they're having a new type of dizziness, we want to kind of characterize it and make sure it's not something new. But these are kind of ways to subdivide it into smaller categories. So dizziness in general is kind of a sense of unsteadiness or imbalance. And it's kind of, I kind of think about it in these 4 different categories. So vertigo is a kind of a type of dizziness. Dizziness is the umbrella term. There's also presyncope, which is kind of the about to pass out feeling, where you feel kind of lightheaded and you feel like you're going to faint, but you don't actually lose consciousness. Disequilibrium is kind of like a loss of spatial orientation. And then psychogenic dizziness, which is, the term isn't really used as much as the others, but that's kind of associated with emotional distress. There isn't a structural cause. It's not consistent with the other types, and it's kind of just its own category. And then vertigo. Vertigo is kind of the false sensation of motion of the environment or yourself. It's kind of like the illusion, most often, of like a spinning motion too. Okay, and we can go into more detail about that too, but we'll move on. So vestibular migraine now. So this is the kind of the focus of the brief talk that I'm giving today. So the diagnosis requires these criteria. So you have to have at least 5 episodes. If you just have a single episode, it might be kind of the early signs of vestibular migraine, but we can't technically diagnose it yet, although we might have a suspicion for something like this. You have to have also a history of migraine in general. So usually the migraine history precedes the vestibular migraine, although they can kind of happen all at once, you know, at the same time. And then vestibular symptoms, which we'll talk about in a second, have to be of moderate to severe intensity. Like they have to be pretty prominent and last, like they can't just last seconds, they have to last 5 minutes up to 3 days at a time. And then you should have these like other symptoms of headache, so of migraine headache specifically. So you need to have at least one of these, and this is kind of getting into the weeds, but just so you guys like are familiar with this or you've seen it before in case this is something that you're concerned about for yourself. So typically people with migraine have light and sound sensitivity. A visual aura is also qualifying for this because visual aura is pretty specific for migraine. That's usually like zigzag lines or flashing lights off to the sides of your vision, which then move centrally, or vice versa. It kind of evolves over time. And usually it's more of like bright lights or flashing lights or something like that, rather than just dark spots, although you can also just have that too. And then or I guess you could have a headache, or you could have all these features, but you only need to have one. So one of them could be a headache, and then if you have a headache, you have to have these additional features, where it should be one-sided, kind of pulsating, throbbing, moderate to severe, and it gets worse with activity. And those also describe migraine headaches too. Those are features of migraine. Okay. So, and then the vestibular symptoms that we had talked about. So this third line here, vestibular symptoms with moderate to severe intensity, can include a bunch of different things. And not to get too into the weeds here either, but this is just different ways of kind of parsing out, vestibular symptoms or types of vertigo. So, spontaneous vertigo, where you have like an internal sensation of motion. External vertigo, which is like where the world seems like it's spinning or kind of flowing around you. Positional vertigo, which can be after a change of head or body position. So like turning over in bed can produce the symptoms, which is kind of classic for like that BPPV syndrome, which if you've had that before, you're familiar with the term. I'm not going into detail with that today, but I'm sure there's other talks on it in the headache school related to headache. And then visually induced vertigo, where you're kind of, you could be in a grocery store with kind of colorful aisles running by you, or you could be in a car and you're just having the motion of the surroundings kind of going by you too. There's also like specifically head motion induced vertigo versus head motion induced nausea and dizziness. And the dizziness is like the unsteadiness or imbalance, kind of disturbed like spatial orientation. So this is kind of like splitting hairs to some degree, but these are kind of ways that we think about vertigo that can help to diagnose things. And once we have once we can characterize things, then we can kind of diagnose it and treat it accordingly. Oftentimes, the treatment is similar when it relates to headache, but if it looks like something that might be related to a structural cause, like a tumor in the brain, in the nerve connecting the brainstem to the ear, or if it's something like something that could be improved by physical therapy, these are the types of features that can help us to parse that out. So vestibular migraine, in terms of like when it happens and who it affects. So it happens a little bit later than it would like without the vestibular symptoms. So migraine on its own typically affects like women more than men, and so does vestibular migraine. But regular migraine tends to occur a little earlier in life, like teens or 20s, where, as vestibular migraine tends to happen a little bit later, like 30s or 40s, but it can also occur anytime in life. The prevalence of migraine is about 16%. It's higher for women, it's lower for men. And the prevalence of vertigo is about 7%. And same thing, there's a slight female predominance there too. Lifetime prevalence of vestibular migraine, like of all comers, of all people, like, just in the population, is between 1 up to close to 3%. So it's not super common, but it's not that rare either. Among people who have migraine, like in general in their life, up to 30 to 50% of people have some degree of vertigo or dizziness sometimes. So it's pretty frequent. Like a lot of people do have these symptoms sometimes, but just by having it sometimes doesn't mean you have vestibular migraine. It has to be, pretty prevalent. And then among people with tension type headache, actually vertigo and dizziness are also more common than it is in the general population, up to 8 to 15%. And that range kind of reflects like the population that we're looking at, or the study that was looking at it, and the kind of, to some degree, the definition of the headache disorder, depending on like what the time frame was. We used to define things a little bit differently 10 years ago compared to now, but it's more or less the same. And then vestibular migraine is more common in people who have a history of car sickness. Even people who had colic as a baby will sometimes ask that question in your headache visits. And then also those who had cyclical vomiting, just kind of like recurrent abdominal distress and vomiting as a kid, usually when they're, like when less than 10 years old, or even like less than 6 years old. And then a family history of migraine in about half of people with vestibular migraine is present. So we always ask about family history too, because it's a strongly genetically inherited disorder. Okay, this is a little busy, this slide, but I just wanted to kind of show it just to kind of introduce like the basic stages of a headache kind of, and just to show that the vestibular symptoms are not always predictable. They can kind of happen anytime, as evidenced by this kind of like just generic green line through all the phases. So so the prodrome is kind of like that first stage of a headache where you kind of like you're starting to feel kind of weird, like you have a difficulty focusing. You might be kind of irritable. You might have fatigue or insomnia. You might have constipation or diarrhea, or even needing to urinate more often. Your neck might get tight or just have generalized muscle stiffness. And then you can start to have some of like the non-headache features of migraine, like the lighter sound sensitivity or nausea. Then you can have the aura, and about 1/3 of patients have aura with some of their attacks. It's usually visual is the most common, as we talked about, was part of the definition of vestibular migraine, but you don't have to have aura to have vestibular migraine. Then you have the headache phase, and for probably most of you, I would imagine you are familiar with that phase. But with migraine, you tend to have light and sound sensitivity, nausea, tends to get worse when you exert yourself. So you try to avoid activity, might want to just stay in a dark room and try to sleep. The headache itself is usually really severe and tends to be on one side, but could be both, and tends to be more like a throbbing, pulsing sensation, but it can be lots of different things, and that is not specific. And then after the headache phase, you have this kind of resolution into the postdrome phase. And the postdrome is kind of where you might still have some residual fatigue or difficulty concentrating, some neck stiffness, and you might still have some of those migrainous symptoms without the headache, or you might have like a milder headache that's residual. And so in older patients, I just wanted to highlight here, as people get older with vestibular migraine, that headache phase can be kind of replaced just by isolated episodes of vertigo, or their headaches might just get better, but they might still have like the kind of the prodromal and postdromal type symptoms kind of before and after their isolated episode of vertigo, which can be like between 5 minutes to 3 hours or 3 days, like we talked about. Vertigo can happen anytime. And then and also and we talked about it, the postdrome phase can also blend in with the other phases. So it can be just like you have like a continuous vestibular migrainous type feeling at all times. This isn't specific for vestibular migraine either. People with regular migraine can just feel kind of migraine-y all the time, and it's kind of like turns into like a headache soup as things start to chronify and become more frequent. But it can be helpful to kind of characterize these different phases, so you kind of know when to take your triptan if you can take one, and how long your headache is lasting, and just so you can kind of get better control to understand your headaches better. Here we go. So this is kind of just fun, interesting, not fun for the people that are experiencing it, but it is an interesting thing academically, at least, that you can have a lot of other symptoms with vestibular migraine. Also, this isn't specific for vestibular migraine. You can get a lot of these with regular migraine, although they are a little bit more common when you have that dizziness aspect of things. So brain fog is the most common, just like mental cloudiness. Things are just a little bit slower. You might have some word finding problems, which is actually mentioned separately, but that can be part of brain fog too. Blurred vision can be present. You can have some autonomic symptoms, which is kind of like lightheadedness on standing, temperature intolerance. Your heart rate can be up and down. You can have like sweating problems, things like that. You can have tingling in your face or your hands, visual snow, which is a separate phenomenon that I know we have talks on by Dr. Degree and others in our headache school if you're interested, but that's it can be a number of things where you have like staticky kind of vision, like you look at a blank wall and you just see these little dots all over the place that are very small. Sometimes you can look at something and then look away and you have like an after image, or sometimes when you're following something that's moving, you can get like a trail of it, like a trailing line or trailing image. That's all kind of visual snow. That's not super common, but it is associated with migraine and vestibular migraine. And then you can have this really unusual phenomenon of Alice in Wonderland syndrome. I've actually not seen it. I've seen it like twice, I think, and at least once, and maybe another time. We weren't really sure if that's what it was, but where you can have a number of weird kind of visual kind of distortions and illusions. So this out-of-body derealization phenomenon can happen. Visual distortions where like colors can look different or kind of hyper real or dulled. You can have like an underwater vision where like it almost looks like things are distorted, like as like you see looking through the water and something's kind of bent at a weird angle, and things can look kind of like that. And then objects can appear smaller or larger than they really are. And this is just a picture of, just like in a drawing of Alice in Wonderland. And in Alice in Wonderland, she shrinks down, and all the shapes and sizes are very strange. And that's kind of describing that phenomenon, which can be seen with migraine and other neurological phenomenons too. But it's just kind of interesting. So that's why I included it. In terms of treatment for vestibular migraine, we have a lot of different options. Although it may feel like you've kind of reached the end of all the choices, there are a lot of different things, and there are even options beyond what I've included in this slide here. But we think about migraine treatment in the nausea, or the acute versus the preventative kind of phases, or different types of treatment. So for acute treatment, we think about nausea medicines like Zofran and metoclopramide or Reglan, Phenergan, promethazine. There's also benzodiazepines like Ativan or lorazepam, diazepam, Valium. These are pretty effective for nausea in general, especially with vestibular migraine, but they have their own problems. They can make you really sleepy. They are restricted drugs. They can cause tolerance and addiction sometimes. So we kind of restrict their use, but we will use them sometimes when we have to. Different antihistamines, some unusual ones like meclizine, which we use for motion sickness, Dramamine, which we use for the same thing, can be helpful. And then some triptans, like these are migraine-specific rescue medicines for headache. And there are a bunch of them, but sumatriptan and rizatriptan seem to have the best evidence for vestibular migraine. We'll sometimes use like prednisone or a steroid burst, like a high-dose prednisone for a few days, and then kind of taper it pretty quickly over the series of about 2 weeks or so. And that can help you get out of an acute vestibular migraine kind of cycle. And then we think about the prevention side of things. So these are things like the regular migraine medicines. So there's the beta blockers, blood pressure medicines like propranolol or metoprolol. There's the antidepressants like amitriptyline or nortriptyline, and then the anti-seizure medicines like topiramate or Depakote. And those are the three main categories of migraine medicines that we typically use. Venlafaxine is another antidepressant. It's a little bit different from amitriptyline, and it seems actually to be pretty effective when there's like a strong like vertigo dizziness component to things, like you would expect there to be when with anyone with vestibular migraine. But if it's just like if the headache is the most debilitating thing, we might consider like the standard migraine medicines. If it's the dizziness, vertigo, we might use venlafaxine first if we think that would be an appropriate fit for you. Verapamil is a blood pressure medicine that we sometimes use in different scenarios, but especially when vertigo is kind of the initial sign of a headache, like an aura, that's thought to be more effective in that situation. Scopolamine patch is just like a kind of like a longer acting version of an anti-nausea medicine that can be pretty helpful for people for prevention, or if they just have chronic nausea, it's a good one too. And then there's these two devices that I've highlighted called the Cephally device, which is that one with like the peach band over his head with the little triangle thing. This is a trigeminal nerve stimulator that's been FDA approved for migraine, and it's effective for vestibular migraine, where you use it for 20 minutes a day for prevention or for 1 hour as needed for rescue. And it just kind of stimulates, it's like a TENS unit. It stimulates the nerve up here and seems to work pretty well for people. It's just neither one of these devices are covered by insurance, so they're a little bit pricey out of pocket, but they can be, they have their role. The other one is this gamma-core or a vagal nerve stimulator. And this you hold right in front of your big neck strap muscle here. And it kind of shocks the vagal nerve. You can do it for 2 minutes at a time and repeat that a few times throughout the day, and that can be helpful too. And that can kind of build up in your or the effect can build up in your system and be beneficial more over time. Okay, and then so briefly on persistent postural perceptual dizziness. Some people call this triple PD or 3PD or just PPPD. It's kind of a ridiculous name, but it is like very descriptive of what it is. And then saying 3PD kind of avoids confusion with this other phenomenon that I mentioned a couple of times, the BPPV, which is different. And don't get hung up by the name. I think just just knowing 3PD is enough, and you can probably type that into Google and say dizziness, and that would be sufficient to to bring up an article or some information about it. But I'll tell you about it now too. So 3PD is described as vertigo or unsteadiness, or kind of like a non-spinning dizziness that happens on most days out of a 3-month period, and it has to happen for at least 3 months. It can occur kind of spontaneously without any sort of provoking cause, but it can be worsened by kind of being upright for a prolonged period of time, like including standing or just sitting. It can be worsened by movement, whether you're like actively moving, like you're walking, or if you are like in a car and you're just kind of passively moving with as the car is moving with you, and you're kind of seeing motion kind of zip by you. And that's kind of the next one, the visual stimuli or complex visual patterns. So even walking in a hallway with like a crazy rug in like a hotel room or something can kind of trigger some of these feelings. And overall, this 3PD phenomenon is interesting in that it can kind of cause these like negative feedback loops where you're feeling more and more distressed. It's causing more functional impairment, which is causing more and more anxiety. You get this fear of falling. You can have kind of agoraphobia, which is like where you don't want to leave your house or leave your room because you're worried that things are going to get worse. And there's this stigma against like feeling dizzy all the time. And so it's kind of its own entity, and it's interesting. It is often it's often started like the first onset of a 3PD diagnosis or like the episode can be triggered by other problems. So that BPPV again, where like the little stones get stuck in your ear canals, not your actual ear canal, but like these little semicircular canals where the body kind of gets its sense of position from. Vestibular neuritis, which was the inflammation of the nerve connecting the brainstem to the inner ear. Vestibular migraine can actually provoke and kind of start this 3PD phenomenon. Sometimes even acute episodes of anxiety, like a panic attack or just having generalized anxiety can trigger, or at least is associated with this diagnosis. Sometimes traumatic brain injuries can cause them. And then just having certain autonomic disorders like POTS or certain types of disorders related to Parkinson's disease and other problems can also be associated with this problem. A quarter of patients who experience like acute or like repeated episodic vestibular problems. So whether it's one of these issues or something else that I had mentioned before, may develop dizziness that could be described as PPBD or 3PD, like 3 to 12 months from then. So, of all the people that develop, this inflammation of the nerve, or BPPV, or any number of like dizziness types of acute episodes or recurrent episodes, a quarter of them can go on to develop this 3PD phenomenon. So it's becoming increasingly recognized as a problem for people. And there aren't a lot of effective therapies, unfortunately, but we do know of some things that can be helpful. So first of all, if you have associated migraine, treating the migraine is usually like one of our biggest things that we really try to focus on. But we also try to focus on other aspects that we can kind of intervene on. So if you're having sleep problems or mood problems at the same time, which are really common, we can help with the sleep and then kind of help with these other symptoms also. Eating well, exercising, regularly, drinking enough water, all of that can be helpful. Vestibular rehabilitation through physical therapy can be useful also. So we'll sometimes put in for a referral to see physical therapy, and they can help a lot too. Cognitive behavioral therapy, which is a really great modality for a lot of different things: depression, anxiety, insomnia, chronic pain, including chronic headaches, and this problem as well, can also be good. And this is kind of like retraining your mind to kind of remove the emotional component of the pain and the symptoms that you're experiencing. If you're interested in this, there's a really good talk about 4 or 5 months ago by one of our speakers in the headache school too, that you might want to check out. And then certain medicines can also be effective. So certain antidepressants like SSRIs, like Prozac or Zoloft or fluoxetine, sertraline, citalopram, those can be effective. And then SNRIs, which are related, but they're a little bit different. That was like the venlafaxine that I mentioned before, or Effexor, or like duloxetine, Cymbalta. They're supported by some kind of lower quality studies, or like the studies themselves are fine, but the level of evidence is not quite to the same level as it is for like regular migraine for various medicines. But there just haven't been any like randomized controlled trials yet. But we do use these medicines, and they do seem to be pretty effective for our patients as well. If you're interested in learning more about 3PD, there's a really good section on this problem on the website neurosymptoms.org, if you're interested in checking it out. All right, and then just in conclusion, since I've kind of been talking for longer than I expected, vestibular migraine is a common disorder that leads to a lot of functional impairment. It can present later in life compared to regular migraines, and a history of car sickness kind of can predispose, or at least is associated with this problem. Patients can experience vestibular symptoms anytime, not just during their headaches. So you can feel dizzy and vertiginous, not when you're just having your headaches, and that can be a kind of a point of confusion. In general, we should get an MRI scan when we're worried about this type of problem, because it isn't classic for migraine, but it is a commonly associated problem, as we've been talking about. And then both, symptoms of both vestibular migraine and 3PD can be unusual and hard to explain, even to a doctor, and they can lead to misdiagnosis. So it's important, if you're having these symptoms yourself, to kind of inform yourself and be aware of it, so that you can kind of talk to your doctors and other medical professionals about this, so you can kind of teach them to some degree, because it's not a totally recognized problem. All right, and that's all I had. Thanks you guys for your attention. I think we can stop the recording.